Good evening, everyone, and welcome to our this. It's a very good session of shoulder joint, and we have two fine speaker with us. One is Rolly Chaudhary. She is from Kokilaben Hospital, and we have with us Jawan Babulkar, Dr. Jawan Babulkar. She is from Pune, and I think we don't need to have any introduction for them. Right? We all know them. They're very good, and everybody knows them. So we'll start with Dr. Raleigh. Can you please share your screen?
Rolly?
Just a second. Can you hear me now?
Yes.
We can.
Yeah. So shall I start?
Yes, please.
Yeah. Good evening, everyone. Today, my topic is a very common topic which we encounter day in and day out in my practice of musculoskeletal ultrasound is adhesive capsulitis. So, just a second. Yeah. So, adhesive capsulitis imaging approach. Just a second. First, introduction. It is also known as frozen shoulder. In the layman language, it is known as frozen shoulder. Uh, uh, it is a very common disease. Why it is called as frozen shoulder? As if you go to the history of this, it was one of the scientists, Duplay, when he described it as scapulohumeral periarthritis, and it occurs when the shoulder joint capsule becomes. Just a second. Yeah. Okay. So it was very long back in history that one of the scientists, Duplay, called it as periarthritis. Then Codman et al. In 1934 called it as frozen shoulder. But in 1945, Nevisser labeled this term as adhesive capsulitis. So adhesive capsulitis, itis means inflammation. It occurs when the shoulder joint capsule, it becomes inflamed, thick, and stiff. So this is the term which we normally use nowadays. For layman language, we use it as frozen shoulder. So they are synonym of each other. Is frozen shoulder means shoulder got frozen because it gets stiff and there is restricted movement of the shoulder. Okay. So what are the diagnostic? I will make my top talk very simple and very understandable with very easy take home points. So first diagnostic, adhesive capsulitis is a clinical diagnosis. It is a clinical suspicion. Diagnosis is based on history and physical examination, whereby a patient is giving the history that suddenly one day, one fine day, when they get up in the morning, they start developing some shoulder pain, which is gradually increasing, and progressively the pain is increasing, and then the stiffness develops, and then it becomes very restricted movement, and then so this progresses. So it is basically gradually increasing shoulder pain for at least 1 month, which exacerbate at rest. They say when they are sleeping in the night, then the pain increases. It is somebody say at least 3 months, someone says 1 month. Normal radiographic findings. So important is inherent intrinsic structural disorder is not there in the shoulder. X-ray is normal. Then, but patient develops severe pain and stiffness with restriction of movement, which progressively increases. More than 30 degrees limitation in gluminohumeral range of motion. It is also known as inflammatory fibroproliferative disease because there is inflammation, then there is fibrosis, then there is joint capsule contraction. So that is the pathophysiogenesis beyond this. Now, staging of adhesive capsulitis. Why I'm describing this? Because patients come to us in different stages. Now, there is two models. One is 3-stage model, one is 4-stage model. So this is basically depending upon the patient's condition. It's 3-stage model is freezing, frozen, and thawing. As the name implies, it is progressive painful stage, where the patient is having pain which gradually and severely increases, and there is some stiffness and some movement restriction. frozen. As the term says, it is progressive stiffness, also known as this adhesive stage, where fibrosis set in. And pain lessens, but the stiffness and the range of movement becomes severely restricted. It's enigmatic and it causes lot of disability and patients discomfort. Then comes the stage thawing, or also known as regressing or resolving stage, where slowly and slowly the pain starts lessening up and shoulder's ability to move gradually improves. So if we had to go to the four-stage model, it also includes a pre-freezing stage, whereby there is early symptoms of pain and reduced mobility. In this pre-freezing stage, if I will label the tenure as it is 0 to 3 months, whereby nobody is able to understand that patient is developing frozen shoulder, she is having some pain, she or he, and having reduced mobility. Freezing stage, actually the time period or the time frame is in various articles which I went through is different. Freezing they normally say is for 3 to 9 months. Frozen stage is from 9 to 15. Thawing is from 15 to 24. It can also increase to 4 or 6 years. Sometimes in some literature they say that patient may also have some pain and restricted motion for many years. But as such, this entity, frozen shoulder, is a self-limiting condition. It resolves on its own, and patient becomes slowly and slowly pain-free. So, what is the role of imaging? As per I read in the articles, according to European Society of Skeletal Radiology, they till now they have not said that we should use ultrasound for diagnosis because it is a clinical diagnosis based on history and physical examination. But we see so many patients, and I have found that ultrasound really plays a role. And on basis of some simple ultrasound signs, it aids in diagnosis and radiographs are usually normal. Another advantage of ultrasound is that it rules out other causes of shoulder pain. Then MRI is problem solving tool. But as always said, ultrasonography, it is very patient friendly, rapidly available, affordable. Then most important thing is comparative study with the opposite shoulder can be done. Second, dynamic assessment can be done. Third, therapeutic intervention. So we will go one by one in it. So, if you want to take a pic of this. This is one take-home slide where I've just labeled all the features of adhesive capsulitis on ultrasound, which I will discuss one by one in detail with images and pictures. So first is the one of the most important sign and very specific is thickened coracohumeral ligament. Then second is increased soft tissue or thickening of the soft tissue in the rotator interval with or without new angiogenesis or hypervascularity on power Doppler ultrasound. Then there is thickening of inferior duodenal ligament, thickened axillary pouch. Effusion in the bicipital groove surrounding the long head is one of the signs, also known as target sign. There can be joint space reduction. Then there is dynamic assessment. Now, we should all be aware of how to see and where to see the coracohumeral ligament and the axillary pouch. There are two techniques seeing it. One is coracohumeral ligament when we are assessing it in its longitudinal axis from the coracoid process. We place a probe on that. I will just show the image and obtain a longitudinal image. But I normally prefer seeing it in the rotator interval where we see it in the oblique axial plane, where, as I will show you now. Axillary pouch. Few months back, I used to find it little difficult looking at the axillary pouch, but by the techniques which I will show you now, oblique axial and coronal scan, it's very easy. You follow the humeral profile, like I will just show you. So the another one take-home slide is this quantitative ultrasound criteria. We are always confused what cutoff we should take. So I went through various articles and I could figure out that we can just consider this as the cutoff coracohumeral ligament and posterior thickening. If it's more than 3 mm, it is significant. The normal is 1.5 to in the rotator interval to 2 mm. Axillary recess capsule or axillary pouch thickness more than 4 mm. It is a very high specificity and very high diagnostic accuracy of 98%. Rotator interval soft tissue normal thickness is 1.7 mm. And if it is more than that, or it is eyeballing, you can see that rotator interval soft tissue. So another take-home slide is this, which we need, and then dynamic assessment. So how to measure it and when to measure, where to measure. So one of the image which we see here is coracohumeral ligament. First way of measuring it. or measuring the thickness is just, you can see how we have rotated the arm. We have just placed one end of the probe on the coracoid and the other end on the level of the humeral tuberosity. And we can see this fibrillar pattern of the coracohumeral ligament. Next, this is the most important slide. Looking at the coracohumeral ligament by keeping the fist on the side, and it's a very simple position where we start looking at the biceps tendon. We just ask the patient to take the hand behind and we see the rotator interval. So this is a one slide. Again, take home. We should know what it is. What is a rotator cuff interval? Rotator cuff interval is an interval between the two rotator cuff tendons. It is bonded laterally and superiorly by the supraspinatus tendon, medially and inferiorly by the subscapularis tendon. The roof is formed by the coracohumeral ligament. And then there is an intersection with the glenohumeral ligament, and which forms the biceps pulley, which helps to stabilize this tendon. So where to measure the coracohumeral ligament? Coracohumeral ligament anteroposterior dimension is measured from the long head of the biceps tendon till the peribursal fat. And this thickness normally is 1.5 to 2. If it is more than 3 mm thick, then it is significant. Another very important we should try in all the patients and we are suspecting adhesive capsulitis is axillary pouch. How to measure the axillary pouch or the axillary recess. This is coronal scanning, which we do. We ask the patient to keep the hands like this. It's like this. We do the coronal approach. It's a very easy way of understanding it is when we see the hip joint, we see the head and the neck junction and you measure the recess. Similarly, in shoulder, we have to see the humeral profile, whereby we see the junction of the humeral head and the surgical neck, and we measure this antero-posterior thickness. So this thickness, if it is more than 4 mm, or another very very important take-home point, on comparison with the contralateral side, if it is more than 60% in thickness, it is significant. So this is how you measure. Another sign, very simple, you see, I said target sign. It is the effusion of the biceps tendon sheet. You see the fluid around the tendon. It's also known as the target sign. This is also a good slide. When we see rotator interval, normally the rotator interval has a slight concave profile. In this, you see when there is thickening of the coracohumeral ligament, there is rounded and convex profile of the rotator interval. This is also a good eyeballing sign. So this, I have repeated these images and again said because this is really important. This is the normal rotator interval where there is no thickening of the coracohumeral ligament. This is in the patient with the thickened coracohumeral ligament. This is increased soft tissue in the rotator interval with new angiogenesis or increased vascularity in the rotator interval, which is also one of the signs which aid in the diagnosis of adhesive capsulitis. So this image, in this image, I'm comparing the axillary recess. So this is normal and this is thickened. This is normal biceps tendon. This is increased soft tissue. This is another very important, slide, which we all should know. What is axillary pouch or the axillary recess which we are measuring? It is an area or the pouch in between the two bands of the inferior glenohumeral ligament, anterior band and posterior band. This is known as axillary pouch. So there are two ways of seeing it. One way is in the oblique axial plane because there are patients with in the frozen phase of the adhesive capsulitis cannot give this position very easily. So this we can also see by following the humeral profile and measuring the anteroposterior thickness of the axillary pouch. And another, which I just said, is by seeing the humeral profile, keeping the arm abducted 70 to 90 degrees. This is a very good take-home slide again. So we should know that there are two ways of scanning the axillary pouch. One is in the oblique axial plane and one is in the coronal scanning. Again, another important point I said, maybe we may not get a exact cutoff of 4 mm, but we are clinically suspecting adhesive capsulitis. Then what should we do? We can compare the normal with the contralateral shoulder then the normal side, if it is affected side is more than 60% thickness as compared to the contralateral shoulder of the axillary pouch, this is also considered one of the important sign. So if it's not fitting in the criteria of 4 mm, but there is a more than 60% difference in the thickness of the axillary pouch, then we should consider it as significant. So this is again, I've shown you how I measure it's a thickened and hypoechoic axillary recess. Another very good sign which we see sometimes is also known as pseudo double tendon appearance. What happens in the birotator interval when there is long head of the biceps tendon and when there is thickening of the coracohumeral ligament, because of this thick, it appears like a pseudo tendon on the lateral side of the long head of the biceps. So it gives like a double tendon appearance. So this is also another sign. Now, what is the importance of dynamic examination? When a patient of clinical suspicion of adhesive capsulitis comes to me, my first very important thing is history. I ask the history of the patient. Is the patient diabetic? Because it's very common. Sorry. Uh, Adhesive capsulitis is of two types, primary and secondary. Primary is idiopathic, secondary, which is associated with post-trauma, post-surgery. I think I missed that slide in the starting. Just go back to that. Uh, just give me 2 minutes. Ah, so primary is idiopathic and where the cause is not known. Secondary is associated with many pathologies, which is very important here is pathology of diabetes mellitus. It is 5 times more common in patient with diabetes. So, so you have to always ask the history of diabetes. It is also associated with other systemic disease like thyroid, hyperthyroidism, Parkinson's, patients with cancer, with stroke, with Dupuytren's contracture. So these are the secondary causes. Post-trauma, post-surgery, forced immobilization is also one of the very important cause. So ideally nowadays they say that you should start mobilizing the shoulder early. Then also it develops in rotator cuff, calcific tendinopathy in the resorptive phase. Patient can develop adhesive capsulitis. So we should be all be aware of these entities, and we should also be aware it's a very common condition, 2 to 5% in normal population, more common in female as to male, 2:1. It is common in middle-aged female, fourth to sixth decade in perimenopausal female, and it can be as high as 20% in patient with diabetes. Important, it affects the patient with sedentary lifestyle. It is common in the non-dominant shoulder. Normally, it affects the one shoulder, but it can also affect in 1/3 of cases the opposite shoulder. Another important point here is one shoulder once affected, it is not affected again. But the contralateral shoulder can be affected. So this is this I thought I missed in the starting telling you. Okay, then I come back to this sign of dynamic examination. So as I was saying, I asked the history of the patient. I always label it that whether my patient is diabetic or not. Then I ask the patient which movement is most painful for you, which movements you are not able to do. So when I've studied so many patients over last 7 years, 8 years, the most important sign of adhesive capsulitis, one take-home point if you want to take, is external rotation restricted and painful. This is the most specific sign. It is the hallmark sign and the more paramount importance. Even passive external rotation is reduced and patient is not able to externally rotate. This is the hallmark finding. Abduction restriction is non-specific because it can be restricted in many causes, but adhesive capsulitis has a typical capsular pattern of restriction of movement. First movement to go is external rotation, then abduction, then goes its internal rotation, and then flexion. So this is classical capsular pattern, but external rotation restriction, painful and restricted external rotation is the hallmark sign of adhesive capsulitis. This I've seen that we all of us know this elbow has to rest on the iliac crest. We place a probe like this medially and we externally rotate the arm. So we this is where the patient is not able to externally rotate. There is lot of pain. It's very stiff, and this is one of the signs which raises alarm in our mind that we are looking at adhesive capsulitis. So this is one of the image where I see in the patient who is able to do the complete external rotation. I can see subscapularis in its entire extent. And in patient with restricted external rotation, only the distal aspect of the subscap is visualized. Sometimes patient can also have subacromial impingement, whereby there is a restricted gliding of the supraspinatus tendon under the acromion. Then there is the same patient also a lot of soft tissue thickening in the rotator interval and axillary pause thickening. One of the new signs which have come up, and I think is of great importance, is infraspinatus dynamic assessment, which is a new sign. I think I found it very interesting. It's also known as bounce sign. What are we actually doing in this? We are assessing the sliding of the infraspinatus tendon during the passive external rotation, which we do like this. I will just
Last slide. No,
we are seeing the infraspinatus tendon from the posterior scapular approach in the log axis. What are we exactly seeing in patient of adhesive capsulitis?
multiple
There is a reduced sliding of the infraspinatus tendon. It tends
prominent
to fold
sites
on itself and over the capsule, and it bounces back.
are
I will
seen
just show a video of the
in
same. You will
mediastinum.
just see how it happens. This when I'm doing passive external rotation, just see this infraspinatus tendon. It
Common largest
comes sliding backwards,
Ah.
folding towards the capsule, and I will again show it. And there is a rapid flitting and jolting movement as it bounces back. It is not sliding smoothly. Just
16 millimeter in short
see
axis
here it is coming. It is again,
in
it is coming
subcarinal
towards the
location.
capsule. It is bouncing
Also,
back. And this is
the
also
subcarinal
represent the
lymph
movement
node
of a
shows
plugged guitar string.
small
So
focal
this
body,
I will again show you. This I have
internal
just seen today in
calcification,
a patient, and I was like, it's really, if it is present, it is a very high specificity for adhesive
lymph nodes के
capsulitis.
पीछे लिखो
So
few
this
common
tendon is bouncing
borderline
back
sites,
in a fleeting,
common
jolting movement. So this
non-calcified
is known as, it is
lymph
bouncing
nodes
back, and this is known as the
are
bounce
also
sign.
seen at
So
pota.
what happens, this is how we do it. We passively externally rotate the shoulder. So what happens, the normal flat profile of the infraspinatus tendon, because it typically drags down and it folds towards the joint capsule because it is contiguous with the capsule. So what happens that this is the flat profile is turned into a concave profile. So this is very classical of the bounce sign. And this also, see, this is in the normal shoulder, and this it is dragged towards the capsule, the profile become concave.
Dr. Raleigh,
Then-
sorry, 1 minute.
Yeah,
Requesting everyone to please keep your mics on mute. Some of the mics are unmuted. Please have a look. Dr. Sharad Gupta, I'm sorry, but yeah. Yeah, sorry, Dr. Raleigh, please continue.
yeah.
Sorry.
So, because why I have shown this sign in such details, because I found it interesting and a new sign, which I think everybody can try when they go to their clinic from tomorrow on, because it really works. If the patient is having adhesive capsulitis, see, it is a normal in a normal patient. And when you do passive external rotation, what happens? This infraspinatus tendon, it folds towards the joint capsule. It became have a concave profile, and this is the angle. So, what is the role of MRI basically? It is a problem-solving tool. It helps in the clinical diagnosis. I have just labeled it because if somebody is interested, these are all the signs, qualitative criteria, features. These are quantitative features, same as ultrasound, capsular thickness, axillary recess capsule, coracohumeral ligament thickness. The criteria are same in MRI, thickness of axillary pulse more than 4 mm, coracohumeral ligament more than 3 mm. In these few images, just to be aware, this subcoracoid fat, it has an abnormal signal intensity here. This is coracohumeral ligament, which is thickened here. Just one slide to make aware. This is abnormal signal intensity in the rotator interval. This is target sign of the biceps tendon effusion. This is thickening of the capsule. This is axillary capsule thickening pouch. So this was just a brief. So treatment, which we discussed in detail by our very own Dr. Zubain, our shoulder specialist, uh, our favorite. So treatment, but I would say it's a self-limiting disease. It normally improves over the period of 2 years. So the initial line of therapy or the treatment is conservative. Non-surgical physiotherapy, physical therapy, sorry, um, Then NSAIDs, oral NSAIDs, then patient is sent to physiotherapy department. Those patients with refractory symptoms, more invasive treatment options are there. One is ultrasound guided injection for pain relief. It can be intraarticular steroid in the bursa or the joint. And what will be discussed in detail is hydrodilatation or the distension, which is also done under ultrasound guidance. So these therapeutic intervention is also guided by ultrasound, which is whereby ultrasound scores over other modalities. This is one of the slide where I'm showing how it's done, but I'm leaving it to Dr. Zubin. So if nothing is working, if patient is having severe pain, symptoms are refractory, and it is not non-surgical therapy is not working at all, then the last mode is surgical treatment, which is manipulation under anesthesia. And then another is arthroscopic capsular release is done. So this is when nothing works and it is in refractory cases. Now, this was my entire discussion. Now, to make it more interesting and more practical, I will just show few cases of patients which are depicting the signs which I just said. For me, history is very, very important. In any patient, the first thing which I said to tell to my residents to take the history, to jot it down properly, to see the X-rays, to see all other clinic orthoped notes. It's very important how they do because clinical adhesive capsulitis is a clinical suspicion, clinical diagnosis. So this was my first case, a 56-year-old male who is a diabetic, presented with shoulder pain. And as I said you, the pain exaggerated wrist. So when he's sleeping the night, the pain is very severe. Movements, the stiff abduction is painful. Because of restricted range of movements, the arc could not be tested. So there was a global restriction of active and passive shoulder movements. External rotation was severely restricted. So if I see this is, as I showed you, was the axial view of the coracohumeral ligament, where you are seeing the thickening of the ligament in the intraarticular portion of the biceps tendon. There is more soft tissue, which is hypoechoic in this ligament. Then as you see, there is thickened and hypoechoic soft tissue with neovascularity on the color Doppler ultrasound within this, which is also one of the signs of adhesive capsulitis. You can also see in capsular thickening here. Incidentally, we also see in this patient few interstitial tears in the supraspinatus tendon. So this was my first case. Second case was a 48 years old female. She came with a progressive pain, which was slowly and gradually increasing in its intensity. Now she's finding it difficult to do her day-to-day activities, overact activities, combing her hairs, dressing. And she says that at night that worsens a lot. And she also has hypothyroidism. So again, if I tested her, active abduction was restricted, passive also gone. Then there is a restriction on the external rotation. So when I saw the transaxillary view of the long axis you see that there is a thickening of the axillary pouch at the humeral profile in the coronal view of the axillary pouch. If I see here, I can see lot of soft tissue thickening in the rotator interval with thickened coracohumeral ligament. So the next case was a 52 years old male with a shoulder pain, insidious onset. Again, patient comes to us when they are finding difficulty in day-to-day activities like combing hairs, reaching the back pocket, doing their normal functional restriction of the shoulder is starting. Pain again at night, and they will not give any history of trauma. In this patient, there was a global restriction of movements. External rotation is severely gone. In this, I would like to say that it was very difficult. She was not moving her shoulder at all. So the images were not that great. But still, I could see that there was a lot of soft tissue here. She was not able to do any movement of the shoulder. She was in a typical frozen pace. I thought axillary pouch was also thickened. Next case was a 50-year-old female. Again, progressive restriction of movements. No history, but she was a diabetic for 8 years. And if we say where does the patient exhibit maximum pain? It is over the shoulder and on the anterior aspect of the shoulder till the insertion of biceps tendon on the anterior aspect of the arm. That is a classical site of pain they will point. And then active and passive abduction is also restricted. So if you see, there is thickening of the coracohumeral ligament. Then there was fluid in the biceps tendon sheet. This is one of this same patient whereby I did did our dynamic evaluation, and I could see. So this is, she couldn't go beyond this. She was having a lot of difficulty in externally rotating beyond this. So I just asked her to fix the elbow on the iliac blade and asked her externally rotating. She said no way she can go beyond this. It is very painful. Even this part, if we see, is very painful to her. She couldn't do any more rotation. So in this, when I scanned her, her coracohumeral ligament was very thickened. It was actually giving a slight appearance of the pseudo double tendon appearance. It was then when I compared the normal axillary pouch with the contralateral asymptomatic side, see again, it is not fitting in the quantitative criteria of 4 mm. But if I compare, it is more than 60% in thickness on the symptomatic side. So it was suggestive of adhesive capsulitis. Now this patient is again 58 with diabetes, progressive deep aching pain, which was worsening and difficulty in dressing. So in this entire checkup was done whereby we also assessed the pain score, the clinician assessed it, and the range of movement also they gave us in detail that flexion, abduction, external rotation, spatially. The key finding was the global restriction, especially external rotation. So he wrote on his paper that he's suspecting adhesive capsulitis, likely in the freezing phase. So this was comprehensive ultrasound assessment was done. We assessed all the ligaments, pulleys, coracohumeral ligament, joint capsule, vascularity on power Doppler. It was quite vascular. I will just show you, and other structures to see whether all other rotator is good. So if you see here, this is the imaging of the coracohumeral ligament of the normal ligament, which follows a clear intraligamentous fibrillary pattern. Here, coracohumeral is thickened and it is hypoechoic. So then this is the normal axillary pouch which we are seeing here. And in adhesive capsulitis, there is this affected shoulder. This inferior glenohumeral ligamentous complex is quite thickened and hypoechoic. So this, and I compared it to the contralateral side. If you see here, there is, this is normal shoulder where the coracohumeral ligament, biceps tendon, and the rotator interval is seen. Here there is lot of soft tissue seen, thickened soft tissue with increased vascularity here. Then if you also see, this is a patient where subacromial impingement in the normal shoulder, there was no impingement. There was smooth gliding of the supraspinatus tendon under the acromion. And you can see the greater tuberosities goes behind the acromion. But in this patient of adhesive capsulitis, also at subacromial impingement, where even on maximum abduction, this is not smoothly gliding. There's interrupted gliding. And what happens? The greater tubercle, it remains outside the acromion, even on maximum abduction. This subscapularis on the normal side, we can see that this was entirely visualized in the complete extent, but in the patient with adhesive capsulitis, only the distal aspect of the subscapularis is visualized because the patient's external rotation is significantly restricted. So these are the angles which you can also see. This is in the normal shoulder with no subacromial impingement. Then the patient with normal or neutral on abduction 90 degrees and in 180 degrees, how it changes. So advance in this patient,
Dolly, Dolly, sorry to interrupt. Can you just wrap it up next minutes?
Yeah, fast. Okay. So shear wave elastography was also done, which is a new thing. In this patient, we just saw thick and stiff coracohumeral ligament. It's a very new modality, needs to be further worked up. So management procedures was done for this patient and outcome was good. Pain score was reduced and movements were good. So I will go fast through these cases. This was again a diabetic patient where everything else was normal. And what we saw is the thickening of the capsular ligamentous complex. And so it was labeled as adhesive capsulitis. Another patient with diabetes, everything normal here, thickened hypoechoic. Again, I'm seeing thickened inferior capsular ligamentous complex. So this was last two cases where patient presented with shoulder pain. This is your thickened CHL, and this can be seen in MRI also. Case 9, patient presented with thickened axillary pouch. We took the MRI images of the same. Last case is thickened coracohumeral ligament and thickening of this. I would like to emphasize today only, this is my last case in one of the last slides. In the morning, this patient came to me, and because I have studied adhesive capsulitis over last few days, I tried to perform everything possible. She had severe pain, which has increased over 3 months. So these are the images which I just added in the evening. This is quite a bit of thickened and hypoechoic coracohumeral ligament with lot of soft tissue and patchy vascularity, thickening of the axillary pouch. I just compared it with the contralateral side. So this is the last video of how I asked him to do the passive external rotation. And this I will show you this bounce sign, which it folded toward the capsule and bounces back. So my conclusion or the take-home message is adhesive capsulitis is a clinical diagnosis. It is a self-limited condition. Always ask the history of diabetes in middle, and it's very common in middle-aged females, perimenopausal females. It's a clinical diagnosis, but ultrasound can help us for early diagnosis, in which we can rule out rotator cuff pathology. Very take-home points is look for the thickening of coracohumeral ligament more than 4 mm. Your rotator interval soft tissue is increased. There can be neovascularity. Axillary capsule or pouch more than 4 mm or more than 60% in thickness with the contralateral side. Then clinically, it's very important. One more take-home point, there is marked restriction of the external rotation movements. So we should all be aware of these 3-4 points. MRI is a problem-solving tool. And very important is ultrasound-guided interventions, hydrodilatation can help in improvement and pain relief. So thank you. And this will be discussed now in detail, the therapeutic interventions by Dr. Jubin. Thank you. And thanks to my DNB residents, Dr. Harpreet and Dr. Kish. Thank you, everybody. Yeah.
Right.
I will stop.
Thank you, Dr. Rory, for that comprehensive perspective and a talk on such a complex subject. So rather, I would put it that this is something very commonly that we see, but we still have lots to understand about this enigmatic pathology. So there are a few questions in the chat box, but what we'll do is we'll let Dr. Joban begin with the talk, and then we'll take all the questions at the end of Dr. Joban's talk. So if that's okay, then I think Dr. Joban, would you
Sure.
like to? Yes.
Should I share my
yes.
screen?
Yes, please. Yes. Yes. Thank you, Dr. Joban, for agreeing to be a part of this, teaching program. And I'm sure that, she's that one person who has so much of in-depth knowledge about this topic, and I think she can teach us lots more. Yes.
Is my screen being seen?
Yes. Yes, please.
Okay. Thank you, Ankit. Thank you, Upasana, for this invitation. Always a pleasure. So I'm going to tell you my experience over the last 7 years. It's been actually, I am actually getting very old in high volume injection therapy for adhesive capsulitis. I think Raleigh's talk was fantastic. Raleigh, the infraspinatus bounce sign, I had no idea what that was. Thank you for telling that to us. I will definitely see it in the next patient that I see of adhesive capsulitis. So, as Raleigh has said, the basic problem of these patients is extreme stiffness, with the external rotation being the most affected. And the clinical severity is really depends on one's experience, and the surgeon will himself tell you that this is mild or moderate or severe adhesive capsulitis, depending upon how much of stiffness that patient has. But what I want to all of you to realize is that basically it is the thick and contracted coracohumeral ligament, which is so-called the essential lesion of adhesive capsulitis. And whatever symptoms and signs the patients exhibit are as a result or secondary to this thick and contracted coracohumeral ligament. Now, please understand that adhesive capsulitis is a clinical diagnosis. They come to us only for ruling out some cause of adhesive capsulitis. As Raleigh said, sometimes you can have a tiny calcification or you can have very tiny rotator cuff tears. because of which the patient goes into an adhesive capsulitis. Now, even if there is a tiny calcification or even if there is a tiny rotator cuff tear, the treatment option is basically a robust physiotherapy program, and most of the patients do very well on a good physiotherapy program. Manipulation under general anesthesia is, trust me, one of the most barbaric procedures that is possible and to be absolutely discouraged. Arthroscopic adhesiolysis is a treatment that used to be done for cases of refractory adhesive capsulitis, but unfortunately that also remains a very thankless procedure, because these patients tend to get a rebound phenomenon of adhesive capsulitis maybe 6 months or 1 year from the surgery. There is really no particular cause, but as Rolly said, diabetic patients, hypothyroid patients have this tendency of thickening of the coracohumeral ligament. It's like some of us get a keloid when you get a wound, some of us don't get a keloid when you get a wound. It's something like that. There is no particular cause why some of us get adhesive capsulitis. Now, remember that the mainstay of treatment is rehab. If you have a mild to moderate adhesive capsulitis, meaning the patient is in supine position, and as Rolly demonstrated external rotation, I would do it in the supine position for one reason. That is, in the supine position, the infraspinatus gets relaxed. When the infraspinatus gets relaxed, their external rotation automatically improves. So if, let's say, the external rotation in you and me, it would be a full 90 degrees. Let us say the rotation is 40 degrees or 50 degrees, and this is a mild to moderate adhesive capsulitis. Then what you may consider is giving an ultrasounded guided bursal local steroid. The only thing that this achieves is a little reduction in the patient's pain, whereby the patients can stick to the rehab program. Unfortunately, the rehab program in patients of adhesive capsulitis is based on a lot of capsular stretches. That's what the physiotherapists do. And some of our patients are in so much pain that that capsular stretch is just unbearable for them. So when you know that the ER is reasonable, there is not too much of vascularity in the rotator interval, the inferior capsuloligamentous complex is not very thick, we are talking about a mild to moderate disease, then you may consider giving a steroid, a local steroid. Usually we give triamcinolone acetonide within the subacromial bursa, thereby reducing the patient's active pain and inflammation so that they are able to stick to the rehab program. Unfortunately, this does not work in cases of severe adhesive capsulitis, and that is the time we are going to do an ultrasound guided targeted injection into the coracohumeral ligament. Now, you target the CHL. The whole idea is to inject a large volume of fluid as a bolus into the CHL. Of course, it is done under visualization at all times, and of course, it has to be followed by a rehab program. Merely injecting fluid into the CHL and letting the patient go has absolutely no meaning. The whole idea is a faster recovery of function. If you followed Rolly's lecture carefully, you must have realized that there is a thawing phase and a freezing phase. What does that mean? It means that if I have adhesive capsulitis today and I am left to my own means, nothing much is done, chances are that about 1 or 1.5 years down the line, I may actually be symptom free. Maybe. Chances are, of course, that it never does, but chances are that you may as well. But do you give that 1.5, 2 years to the patient, let the patient be in pain for 2 years without any function? No. So the whole idea of this is that the patient gets a faster recovery of function. What are the patients that we include? Primary stiffness of the shoulder, ER, IR. ER in the supine position less than 20 is what you do HVI for. Of course, most of them have an associated global stiffness. Which are the patients you do not include? Most definitely case of primary osteoarthritis. Why? Because patients of primary osteoarthritis obviously also have a reduced external and internal rotation, but their pathology doesn't lie in the CHL. Their pathology lies in the glenohumeral joint. There is no point in doing that high volume injection. and the other is a full thickness cuff tear. Now, if a patient has a 10 millimeter supraspinatus tear and associated stiffness, you have to correct the rotator cuff tear first. The stiffness will go because of correction of the rotator cuff tear. What do you use? So we use local anesthesia, usually 2% lignocaine. And then we inject a bolus. What is that bolus made up of? You take a 20 cc syringe, out of which you have 15 cc's of normal saline, sterile saline, about 3 to 4 cc's of sensorcaine or bupivacaine, and 40 milligrams of triamcinolone acetonide. If your patient is a diabetic, if the HbA1c is high, then you eliminate the steroid. The result of this HVI does not depend upon whether you use a steroid or not. It is the bolus of fluid that is injected at high pressure. Now, how do you locate the CHL? I think Rolly showed this to you. So this is the long head of biceps in the bicipital groove. I'm tracing it cranially in its short axis. And this bright thing that you see in between the LHB tendon and the peribursal fat is usually where the coracohumeral ligament is located, just anterior to the intra-articular portion of the long head of biceps, and that is what we target. So this is my needle, this is my needle that is there within the intra-articular, within the rotator cuff interval targeting the CHL. You see the patient position. Patient is always supine. By and large, do all procedures in the supine position. It's just far better for both the patient and you. You use a lateral to medial approach, and you usually inject about 4 to 5 cc's of 2% lignocaine within the coracohumeral ligament, that is the rotator interval, and also as you withdraw the needle into the needle path. And I also like to raise a very nice wheel that really helps the patient for the next injection. After this, you inject the bolus. So again, this is the bolus coming up. As you saw, there is a sudden spillage of this whole bolus into the rotator, into the subacromial bursa, and that is expected. You cannot expect 20 cc's of this fluid to go solely into the coracohumeral ligament, but that's okay. Many times, as we are doing this injection, we actually perceive a pop. Unfortunately, I cannot demonstrate that to you because it's just something that you perceive as you're injecting it. And always, the people in whom we perceive this pop are the ones who do far better on this procedure. After this procedure, we can see these tiny echogenic foci within the CHL so that you know that you have correctly targeted the CHL. And these are the pre and post HVI videos of the same patient with his like 10 minutes after the procedure. As you can see in the pre-image, his external rotation is at the most 10, and it has gone to 70 in the post HVI, post after the HVI. And you can imagine how easy it is now going to be for this patient to retain the rehab program. Now, when we started doing this procedure, one of our patients experienced a slight dizziness, almost like a very subtle vasovagal shock. And I realized that she had not eaten anything. So from that day onwards, I have always encouraged my patients to have heavy meals prior to the procedure, basically because we inject a 2% lignocaine. I do not do this procedure if the patient is starving for any reason, Navratri upas, nothing. You have to go eat sabudana khichdi and come back. Also, when we target the coracohumeral ligament anterior to the long head of biceps in the rotator cuff interval, many patients have a sort of a searing pain that runs down their anterior arm, and this is most likely because of the irritation of the long head of biceps. The long head of biceps in the shoulder serves only as an irritant, a pain giver. It really has no other role to play in the biomechanics of the shoulder. So when we started experiencing this with many patients, we thought, can we do anything different? And I realized that this is the long head of biceps, this is the CHL over the long head of biceps, and this is where we were targeting. But if you have to target the CHL, you can target it at its coracoid attachment as well. Now, The question will remain whether the rotator interval is, if it's not being targeted, does it really change anything for the patient? But as I said, we are working on the principle that a thick and a contracted CHL is the basic pathology as far as the adhesive capsulitis is concerned. So now we decided to target the CHL at its coracoid attachment. So if that's your LHB, that's the coracoid. This is the whole coracohumeral ligament just overlying the subscapularis tendon. So now what do you do? So I have purposely marked some landmarks on this patient's body. So that's the coracoid. My probe is, you first identify the coracoid in the short axis and then go long axis on it. Remember that medial to the coracoid process is our brachial plexus. So you do not want to go medial to the coracoid process ever. So you translate the probe on the coracoid process as lateral as you can, but you keep the coracoid process in view because bony landmarks are always very good. And then first, obviously, you inject a good 2% lignocaine into the coracohumeral ligament at its coracoid attachment and along the path, raise a nice wheel. And after that, you inject this big bolus, which is made up of almost 20 cc's of fluid into the coracoid attachment of the coracohumeral ligament. Again, it is inconceivable that 20 cc's will go into the coracohumeral ligament. You do expect a bursal spillage, but that's all right. No harm done as far as that is concerned. Now, a lot of people ask me this question, therefore, I'm going to address it. Does thickness of the CHL change your management? Now, this is really controversial, but trust me, I've been doing this for the last 7-8 years. Many patients who have external rotation 0 often have a completely normal looking coracohumeral ligament. My take on this is, do not change your decision of doing this HVI just because you don't see a thick CHL. If the patient's external rotation is 0 or -10 or +10, then irrespective of the thickness of the CHL, this patient deserves the high volume injection. What you can do is what I have done in this particular patient. That is using a 16 gauge needle. Otherwise, I would be using a 18 gauge needle for this particular maneuver. Instead, in patients who have a thick CHL, who have external rotations in -10 or 0, we use a 16 gauge needle and we do something like a fenestration or a dry needling of the CHL, as you can see in this particular video loop. This really helps in not only injection of this entire bolus into the CHL, but also improves their external rotation in our experience. So this is the pre and the post procedure image of the CHL at the coracoid attachment. This is the coracoid process. This is the subscapularis. This is the CHL. And you can see that fluid is now surrounding the CHL because we have fenestrated it and we have injected a bolus into its coracoid attachment. Of course, we give them pain medication, usually something like a Flogam for 5 days and either a Ultra Day or a Ultraset for 5 days. They have to do physiotherapy either on the same day or the very next day. And they are typically followed up at 12 weeks and then later at 24 weeks. So this is now pre and post HVI at the coracoid attachment. And as you can see, an external rotation of 10 has almost gone to 60 or 65. There is, trust me, there are only some 5 or 7 minutes between these two videos taken. So what we have found that if a group of patients does only rehab and another group of patients does HVI followed by rehab, then they have a very fast recovery of function. This is a study that we had done 2 years back, and we found that their recovery of function, the improvement in the recovery of function is statistically significant after you do an HVI. Remember that our results are pretty much the same whether we inject at the rotator interval site or at the coracoid attachment site. I was pretty flabbergasted actually when I prepared this lecture that we have done almost 850 HVIs starting from February 2018. When I presented this at Toledo in 2022, we had just started doing this at the coracoid attachment. But since September, Jan of 2022 to till date, October 2025, we are only doing it at the coracoid attachment, and the results are absolutely the same. The maximum increase in external rotation that we have achieved is 60 degrees, so 10 to 70 or 0 to 60. Some patients don't respond as well. The minimum increase, however, is definitely 20 degrees. So if you have had a 0 external rotation, it will go to 20. Okay, that's the bare minimum that you can achieve. On an average, most of our patients have an improvement of 30 to 40 degrees on table. The advantage of doing an injection at the coracoid attachment site is there is no pain along the long head of biceps tendon, which was a genuine problem that we were facing when we were injecting into the rotator interval site. So what is my conclusion? First of all, the gains of injections are statistically significant as compared to patients who do not receive a HVI followed by rehab. There is no difference in results whether you inject at the rotator interval, whether you inject at the coracoid attachment. This is most important. Whether we inject steroid or not, the results are the same. The steroid does not change the improvement in external rotation at all. And this is something I wanted to include. Those of you who have seen the latest F1 movie will realize what this is. The others who have not, please see it tonight. This is a very beautiful dialogue in the movie. Slow is smooth, smooth is fast. What does that mean? It means that whenever you are doing any procedure, any intervention, be slow and be steady. Don't rush into things that you feel are indicated. The patient should always deserve that intervention. Only then that patient will be really, really benefited by whatever intervention you do, shoulder or in anywhere else in the body. I'm going to end my talk by calling for posters for an ultrasound CME, the first exclusive nerve ultrasound course that we are having on 11th of January at Bharati Hospital. So if any residents are attending, please send us posters. We will be happy to have you on board. I think that was my last slide, Ankit. Thank you very much.
This is just fantastic. Thank you so much, Dr. Jovan, for this wonderful talk. And I think every time I listen, I take home something with me. Yes,
Thank you so much.
yes, this is wonderful. Yes, Rajas, Dr. Mohit. Okay, so if there are any questions, feel free to ask. So we'll start with some of the questions
Yes,
over
I
here.
was just looking there.
Correct.
Yeah.
So the first one is there any difference in the axillary pouch thickness according to the amount of shoulder abduction?
Yes, Rolly,
Yeah.
you can take this one. Yeah.
So when there is a difference. What is axillary pouch is exactly a space between the anterior and posterior band of the inferior glenohumeral ligament. So when the arm is abducted 0 degrees, then it is very lax and it is folded. So it will appear thicker and falsely thicker and corrugate. And if the arm it starts abducting at 45 degrees, then what will happen? Slowly the tension will increase and it will stretch. The thickness will decrease, but at 70 to 90 degrees, where we normally want to measure it, it is stretched properly and it becomes thin and smooth in normal patients. So the criteria which we used is in the abduction at 70 to 90 degrees. So definitely that plays a role. Yeah.
Okay, so I have a thought on this. So if you look at the MR images, so all the MR images that you measure the thickness, it's all in the neutral position,
Yes.
Yeah.
right? You're unable to do that. So there's always going to be some, discrepancy within that. And
True.
how many
And
patients are going to be able to do that 70 to 90
exactly.
degree
I was just
abduction?
going to say
Yeah.
that. Yeah.
I have found that when the patients are not able to do that, then the other thing is oblique axial plane we measured, na? Where they are
Correct.
ducting the hand slightly and we are measuring it in the axial plane. I showed both the ways. So mostly the patient, when it is in the frozen phase, severe pain and restriction, for them it is difficult to give that coronal images. But if you see, it is very easy to measure in the coronal plane compared to the axial plane. What will you say, Dr. Joven?
I
Can
agree. I just feel that these patients are in just too much pain, and any movement is very difficult for them. So if you can manage to give them this position, nothing like it. You can actually measure the axillary pouch. But if not, it really doesn't change any diagnosis. So you should probably just let it go.
Yeah. So many
sometimes you
times,
can use the TVS probe to put it in the axilla.
Convex,
Yeah,
convex, convex.
always convex.
I prefer convex.
yeah, convex.
Yeah.
And very Nidhi ma'am is not here today, but during her last, when we met, she said us, like as you see in hip joint, we are so used
Yes,
to the joint, anterior joint recess,
correct.
the junction at the femoral neck. So similarly, it's very,
I agree.
if you put that in your brain, and if the patient is not in that frozen phase, is in the freezing phase and they are able to do, then you have to just connect the head with the neck and measure the axillary pouch. It
Absolutely
comes
correct.
very beautifully.
I agree.
You can try, everybody can try
Yeah,
when they go
it
to
does.
the clinic next day. Yeah.
Actually, with convex probe, it is far easier.
Yeah, I agree. I agree. Even hip joint, because
Yes,
there is always a lot of fat there. Yeah, it's difficult. It's quite deep. So
correct.
with the convex probe, it becomes very easy. Yeah, I agree.
Okay, so we have another question from Dr. Varsha. She's asking, what is the difference between rotator interval soft tissue and coracohumeral thickening? Is there?
Uh,
So,
shall
so
I
how do you
answer?
differentiate? Yes, yes, please.
Yeah. So when we were talking about rotator interval soft tissue, coracohumeral ligament, as we know, is a ligament, which is a band-like structure, which is very, very defined. It is between the it is forming the roof of the rotator interval. It is between the coracoid process and the humerus. It is on the superior aspect of the rotator interval. But the soft tissue is all around the biceps tendon in the rotator interval, which includes the inflammatory tissue, your synovial proliferation, your fibrotic tissue, and it's very ill-defined. You can measure it. Coracohumeral ligament is very well defined, band-like structure, which we know its anatomy. And soft tissue is all around the biceps tendon, involves all the inflammatory and fibrotic tissue. Yeah.
Can you differentiate it, the ligament and the soft tissue in your ultrasound? Can you
Yeah.
differentiate and measure?
Coracohumeral ligament we measure at the floor roof
No,
of
at the roof of the rotator cuff
Yeah,
yeah,
interval.
I think Rolly did show a couple of
yeah,
images with the vascularity.
in the soft tissue in the rotator. Yeah.
But in
Yeah.
some article, they said the soft tissue, rotator cuff soft tissue, is exactly measured over the rotator cuff interval. They said we should measure the coracohumeral ligament near the attachment site.
Okay.
And whatever we measure over the cuff tissue, rotator cuff
Yes,
interval, that is the rotator cuff soft tissue thickness.
that is correct. That is
Because it
correct.
includes
Because
the
it,
capsular fibers, synovial
yes,
tissue,
I
and
think I
everything.
think when there is lot of inflammation, there is a whole lot of hodgepodge that is going
Yes,
on in
yes.
the rotator cuff
That's
interval.
why there is increased vascularity.
Correct. So then when in that case, probably you will measure it at the coracoid. So
Yes.
that's what I was trying to say. There are so many articles which tell you
So
so
many
many different
difference of
thicknesses.
cutoff also, no? There
Yes.
are different
But
different.
when
Yeah.
I would say when you're doing many cases, Upasana, I think eyeballing also works.
Correct.
Times
Obviously,
because we see so
obviously.
many normal shoulders, and as soon as you see that soft tissue and that you are like
You can make
your,
out.
in your brain you start thinking when there is a
The
clinical
best thing is to
suspicion.
always correlate clinically. Always
Yeah,
clinically you have to
clinical
correlate.
diagnosis. Yeah.
And not
Or
necessarily, I think, I don't know what you all will say, but sometimes CSL may not be so thickened, but posterior capsular complex is very thickened. And that is, in most of the cases, that is, I can say it more confidently when I see the thick posterior capsule.
accurate.
You mean under the infraspinatus?
Nay, on the axillary pouch.
that
Okay. True,
is
true.
inferior
True,
capsule.
true, true.
inferior
Yeah.
ligament.
Yeah.
But for me, I think when I start the patient, external rotation, if it's very restricted and painful, and there is a clinical suspicion, though I start making my mind that maybe I'm going to get signs of
Correct.
adhesive capsulitis. So I would like to say everybody that that's really an important sign, which
True.
you should take care, means see. Yeah.
Okay, so there's one important point which Sonali has put up is sometimes there are symptoms and clinical features of frozen shoulder, but suddenly we find a supraspinatus tear. So, what do you make out of it? Is the supraspinatus tear which is more important, or is
Yeah.
it the frozen shoulder which is more important?
Right. May I, Rolly?
Yes, yes,
Yes.
please.
Yes.
Please.
So, see, I think this is a very pertinent question. Now you have to understand that if you have now all of you, I'm sure do lot of 3T MRI, especially the young ones. And I'm sure that you come across these 1 millimeter, 2 millimeter, 3 millimeter tears, which are full thickness tears, insertional tears, but nevertheless tears. What we have to understand is that these tears now, these tiny tiny tears, they don't operate, they never operate there. The treatment of those patients is rehab. Any tear which is more than 9-10 millimeters, they will consider surgery. Now because of a tiny rotator cuff tear, let's say I have a 2 millimeter supraspinatus tendon tear, because of which I have gone into a secondary adhesive capsulitis, then it is definitely worth thinking that this is primarily a adhesive capsulitis pathology. Yes, there is a tear. Yes, the adhesive capsulitis is because of the tear. Perhaps, we don't know. But now what do I have is adhesive capsulitis. So I have to be treated as an adhesive capsulitis patient rather than a rotator cuff tear patient. I hope I am clear.
Yes, I think you have made a fantastic point over here. For the simple reason is this is what we see, of course, in non-experienced surgeons. So what happens is they go after those partial thickness tears,
Yes,
small thickness tear. They will operate, they will fix that tendon. But you have to understand that that process of frozen shoulder will still continue.
correct.
That freezing, thawing phase will still continue. So the patient is going to be an unhappy patient and it's going to be disastrous.
Very,
So
very true.
See, the
that's why a lot of patients will not do well, even after
Correct,
the cuff is repaired.
correct.
the problem is where when the patient is like literate, he said, I have a tear, but you are treating as adhesive capsulitis. So
Yes,
the convincing patient is very difficult, whether
I
it's
agree.
small tear or large tear.
I
In
agree with you. But I think this is where you have to have that communication with your referring surgeon and say that yes, there is a tear, but the predominant pathology is adhesive capsulitis because 1, 2, 3, 4, these are the things that I'm seeing.
okay, okay, yeah. Thank you, thank you.
Yeah.
Okay, so let's see.
Another question.
Yeah, do we have any?
Barsa is asking another
Okay,
question.
so so Dr. Varsha is asking the coracohumeral ligament measurement. Where do you measure? Should you do it at the coracoid attachment or at the
I think
site
we
of?
already addressed that.
Yes, correct,
Yeah.
correct.
Yeah.
Okay. So, Dr. Gino wants to know once again, high volume injection is into the coracohumeral ligament or is it around the coracohumeral ligament? So,
We
is it
try
within
to
this?
do it. We try to, the needle is within the coracoid attachment of the CHL. Okay, it is within. Now, as I said, I repeated that sentence twice. It is inconceivable that 20 cc's of fluid will go into the coracoid attachment of the CHL. So, although the whole skill is to try and hold that tip of the needle at the coracoid attachment and inject. Obviously, it goes around the CHL. It cannot just pool there, no? It will go around. There is another question. Do you do intra-articular saline hydrodissection? No, we don't, because the pathology for adhesive capsulitis is not within the joint, within the glenohumeral joint. It is in the surrounding capsule, which is basically the coracohumeral ligament. So if you want to do an intra-articular injection for some other thing, you can do an intra-articular steroid injection. But for adhesive capsulitis, no, not intra-articular. The other thing is, if these patients ever get operated, the surgeons don't like any extra thing going into the joint space because it's an invasion of a pristine joint. So that is another reason why you should 100 times think before doing any intra-articular joint injection.
Okay, one more question. Do we hold back steroid in adhesive capsulitis patients with a partial thickness tear, or do we need MR confirmation?
Meaning I'm presuming that your question is whether to add steroid or not depends on what. So the
Eh,
addition of this steroid is in all non-diabetic patients, irrespective of whether they have tears or not. Again, a very low grade partial thickness tear with a secondary adhesive capsulitis definitely needs a high volume injection. If it is a high grade partial thickness tear, let us say a near full thickness tear, then that's probably going to require surgery. Then we obviously need to go down the MRI path and a pre-operative kind of path. You need to judge that. Tiny partial tears, nobody is going to touch them. Tiny partial tears with an external rotation of 0 definitely needs an HVI. The steroid, the decision of a steroid is only in whether the patient is diabetic or not.
Correct. Okay. So yeah, so that's great. I think Dr. Joban has really answered all the questions really well. If there's anybody else, if they want to ask anything, otherwise, we can kind of conclude the session.
Yes.
Sure.
So
Any
great.
any role for intra-articular injection?
No, that's what I said.
Oh, no.
The pathology of adhesive capsulitis is not within the glenohumeral joint. If it's early OA that you're thinking of and the patient is really suffering, you can contemplate an intra-articular steroid injection. But intra-articular saline hydrodissection will not change anything for the adhesive capsulitis. The whole purpose is to improve the external rotation. Think about it, visualize it in your head. How do you improve external rotation? It's by stretching out that contracted coracohumeral.
I think
I
the
think,
the voice
Joel,
is not coming.
yes.
The audio is not working for Dr. Zubair.
Correct. So
So what Rolly said about bouncing sign, no, Rolly?
Yeah.
Actually, there is a new classification of adhesive capsulitis, depending on that.
Okay.
So it's a recent one. So
Yeah.
that is by Nata Groveler.
Yeah, not at all. Yeah.
So
So what does that say?
that's divide the stages depending on that sign.
Okay. I found it
okay.
very interesting. And
Yes.
today, when I found a patient on which I can do, so I tried, and it's easy because normally we see infraspinatus tendon in that plane and the posterior aspect, and we do external rotation. And so we can, in all the patients of adhesive, I think we should try.
Yeah,
Come.
very good. I will try, indeed.
Yeah.
Come back.
I think, madam, we lost you somewhere in between. I
Yeah,
think
yeah, that's fine.
you were saying
That's
something.
okay.
Yeah. Okay.
But
Great.
this
Great.
is really very nice and very informative.
Nice.
And
Yes.
thank you so much,
Thank you.
Jovan and Rolly, and
Thank
lots of
you.
love to both of you.
Thank
Thank
Great.
you,
Thank you
dear
so
Thank
much.
you.
Upasana, Ankit. Thank you.
Yes.
Thank you,
And
everyone.
thank
Bye.
you for all the delegates for joining in. Yes, it's a festive season, so you're away from the family and all, but thank you so much for joining in. Yes.
Thank you.
Thank
Thank
All
Thank you.
right.
Bye.
So
Good night.
Bye. Good
and
night.
happy
Good night and
Diwali,
happy
Happy
everyone.
Diwali.
Happy
Happy
Diwali.
Diwali to everybody.
Happy
Thank you.
Diwali, everyone.
All right.
Bye. Bye.
Thank
Bye.
you.
Bye. Good night.
Take care.
Bye.